Thank you all for joining. A very good morning. We'll begin the proceedings with a word of prayer. I'll request Reverend Thomas Hutchin to start.
പ്രാർത്ഥനയ്ക്കായി നമുക്ക് എഴുന്നേറ്റ് നിൽക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധായിക്കും സ്തുതി ആദ്യമൊന്നേക്കും തന്നെ. ആമേൻ. മഹാപരിശുദ്ധനും നീതിമാനുമായ ഞങ്ങളുടെ സ്വർഗ്ഗസ്ഥ പിതാവാം ദൈവമേ, അങ്ങ് ഞങ്ങൾ സ്തുതിക്കുന്നു, വാഴ്ത്തുന്നു, വന്ദിക്കുന്നു. കാരണം ഒരു പുതിയ ദിവസം കൂടെ കാണുവാൻ അങ്ങ് ഞങ്ങളെ സഹായിച്ചു. പ്രത്യേകിച്ച് ഈ മാസത്തിൻ്റെ 3-ാമത്തെ വ്യാഴാഴ്ച ഞങ്ങൾക്ക് ഇവിടെ ഒരുമിച്ച് കൂടുവാൻ സഹായിച്ചല്ലോ. ഇന്ന് ഞങ്ങളോട് സംസാരിക്കാൻ പോകുന്ന ഡോക്ടർ ജിത്തിൻ്റെയും ടീമിൻ്റെയും ഞങ്ങൾ ഓർക്കുന്നു. ഇന്ന് അതും ഞങ്ങൾക്കൊരു അനുഗ്രഹമായി തീരുവാനും മുൻപോട്ടുള്ള ഞങ്ങളുടെ യാത്രയിൽ അത് മറ്റുള്ളവർക്കൊരു അനുഗ്രഹം പകരുന്നതായി തീരുവാനും ഞങ്ങളെ സഹായിച്ചാട്ടെ. പ്രാർത്ഥനയായിട്ടതിനായി സ്തോത്രം. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തു എന്ന നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, everyone. Today we gather to celebrate World Anesthesia Day, a day that marks one of the greatest milestones in medical history. On October 16, 1846, at the Massachusetts General Hospital, anesthesia was used successfully for the first time during surgery. This singular event transformed medicine and surgery forever, turning surgery from an ordeal of agony into a field of precision, safety, and compassion. Anesthesia is more than just putting patients to sleep. It is about relieving pain, ensuring comfort, and safeguarding lives, both inside and outside the operating room. From labor analgesia to intensive care, from emergency medicine to pain management, anesthesiologists stand silently at the heart of every successful procedure. As we celebrate World Anesthesia Day, it is fitting that we reflect not only on science but also on service, on how we bring comfort and healing to those in pain. In anesthesia and pain medicine, this calling becomes very real. We are instruments of God's compassion in moments of fear, suffering, and vulnerability. I remember a little more than 2 years ago when GC Sir came back from his surgery of the shoulder in Vellore. He came and met us and said, I want you as a department to consider and take up pain very, very seriously in this hospital. We thought we were managing quite well till that point, but Sir pushed us to a whole new realm. He insisted that this was not an option for our patients, but this is something that we need to pursue with all diligence, with everything that it took, not just acute post-operative pain, but even chronic pain. And I think that is what pushed our department to pursue this. We were quite happy the way we were going till then. And it is just the grace of God that we had two very sincere and accomplished persons who took up this call. And I think they just fit this field of pain so beautifully, not only in terms of their service and their calling, but also in their skills and knowledge of pain. As a department, we took this up wholeheartedly, and particularly Dr. Nimmy and Dr. Jithin took up this area of acute postoperative pain and chronic pain. I won't waste your time. I want you to listen to them as they speak about both these aspects of pain. And so I'd like to hand over the stage to them. We'll begin with a talk by Dr. Nimmy, who will discuss about how postoperative pain developed, the services developed, and how we are looking to develop this more in the future, followed by Dr. Jithin, who will talk to you about chronic pain. It's an entirely new field, an entirely new arena that we are looking at, and we are so ably supported by our management here. I don't have words to describe how Sir has supported us so much over the last 2 years, and particularly this last year. And we really don't know where we're going, but I'm sure it's a wonderful place that we're going to. Thank you very much, and I hope that you'll enjoy these sessions. Over to Dr. Nimmy.
Good morning, everyone. Today I will briefly walk you through the acute pain services provided by the Department of Anesthesia. Now, what is a patient likely to remember about their surgery? I don't think it's the duration of the procedure or the sutures used. What they may never forget is the pain. Unfortunately, pain is an inevitable part of surgery. Now, we had a 70-year-old male who underwent an open sigmoid resection with loop ileostomy. Now, this is a major surgery where we anticipate a severe degree of pain. Now, traditionally, this patient would have been put on systemic analgesics, which would have resulted in severe pain and delayed recovery. Now, how are we going to approach this differently? We are uniquely placed to solve this issue, not just as an anesthetist, but as a perioperative physician who will accompany the patient throughout their entire surgical journey, right from the time they are admitted till their discharge. Pain, post-operative pain, is not very uniform in its distribution. It is affected by patient, surgical, and anesthetic factors. Therefore, it is very important to stratify these patients so that we can develop an individualized approach for each patient. There is also this specific need to engage the patient in their pain journey, so they have realistic expectations post-surgery, and also involve them in planning the analgesia. During surgery, the goal of optimal analgesia is not zero pain. It's a manageable degree of pain so as to enable recovery with a balance of comfort, safety, and function. And the goal of preventive analgesia will be to prevent sensitization of the central nervous system so that patient will have less post-operative pain, and also there is less chance of development of a chronic pain. Both of this is achieved by a multimodal analgesia in combination with regional techniques, which we are emphasizing a little more on, together with daily pain assessment in the post-operative phase. I'm sorry, it's not very clear, but this patient underwent the procedure under GA with epidural. He was followed up till day 5 because he was having an epidural. On most of the days, he had a pain score of 4 and 5, except on one day, post-operative day 3, there was a big breakthrough pain when he gave a score of 6, and we were able to intervene with an epidural top-up. So what exactly changed for this patient? So stable intraoperative hemodynamics, adequate intraoperative analgesia, we were able to extubate the patient. Then daily pain rounds and assessment helped us to identify his breakthrough pain and intervene accordingly. Similarly, he was made to sit on the bed on the first post-operative day and was walking with support on the second post-operative day. So it enabled his early mobilization. More emphasis on regional techniques also ensured that less of opioids were used and therefore minimal side effects related to the same. Apart from post-operative pain, we also provide services to pain related to trauma and other medical conditions like pancreatitis. Now, how it all started. Like ma'am rightly said, the foundation stone was laid by none other than our dear sir, who happened to see a few patients struggling in the post-op, and also the awareness that probably systemic analgesia was not just enough. So we started with the basics, mapping all the pain points, making an SOP, forming a core team, also identifying high-risk surgeries with a high pain burden. The next month, we started procuring essential equipments with a little bit of training sessions for the residents and staff. We developed pain assessment charts and documentation tool, and also planned to integrate regional techniques in selected cases. This was initially rolled out in gastrointestinal surgeries because these patients were already under the ERAS protocol. So good pain control was essential for the recovery of these group of patients. And rounds were also started by the team for these patients. We collected data on the scores, rescue analgesia, and also patient feedback. Later, we decided to extend this to other departments like orthopedics and general surgery. We also introduced standard blocks like an adductor canal or a femoral block for TKR patients, both unilateral and bilateral. Later on, we started procuring standard drug kits for delivery of our services to locations like the ICU and the HDU. So by the end of the 6th month, we started auditing our what we were doing and also tracking on the pain scores and rescue analgesia. So now by the end of 1.5 years, we have a very structured and functional acute pain services. We have 4 dedicated staff who are available 24/7, covering all patients. All post-operative patients are seen daily, at least twice, with systematic review of some patients even up to day 7. All surgeries are included, and we are also expanding blocks prior to shifting the patient out of the post-op by giving lots of truncal or a facial block. Just a few data that we collected. We realized that the pain score reported by the patient was little higher in patients that just received GA. Like I said, we use only systemic analgesics in GA, but a GA combined with other techniques, mostly regional techniques, gave a little lower score of 3. This is the data of patients who underwent bilateral TKR. All these patients are put on an epidural overnight. Most of them again gave a pain score of 3. Unilateral TKRs are also given adductor blocks immediately after surgery. They also reported a pain score of 3, most of them. These are some of the additional blocks that we give in addition to the blocks given to post-op patients: claudication pain, rib fractures, and also rescue blocks that are provided to patients who have pain even in the 3rd or the 4th post-operative day. What our surgeons have to say? They were quite generous in their rating for us. But yes, we still need to work on effectiveness of pain relief, pain satisfaction. Getting a 5 out of 5 means 0 pain. It is quite difficult, but we will definitely work on that. They also suggested that we provide arrival blocks to trauma patients in the ER, and also, if possible, introduce patient-controlled analgesia. Before I close, I would like to thank my team, both my colleagues and technicians, for their unwavering support. My PGs, who have been part of the daily morning rounds in spite of their difficult duty schedule. My surgical team, we are very obliged with your input. It helps us to improve and learn. Last but not the least, the backbone of our team, my nursing staff. I know it has been a difficult journey, understanding anesthesia, understanding pain, but your vigilance, your teamwork, and your compassion makes a lot of difference in the recovery of the patient. And also to dear sir, you sowed the seed and brought this vision to life. Thank you so much.
Good morning, all. Warm greetings again from the Department of Anesthesia. So good to have you all with us. So encouraged by what is happening today. As ma'am was taking us 2 years back when we had multiple calls from our director calling us, we need to do something about pain, we need to do something about pain, we need to do something about pain, and that helped us move on. So I have titled today's talk, A Brief Introduction to Interventional Pain Management at BCMCH. A quick word about the burden of pain that we have. Chronic pain affects about 20 to 30% of adult population. And 1/3 of those patients will have some sort of functional disability limitation, and 7% they categorize as what they call high impact chronic pain. High impact chronic pain. And this number that we're going to see now is staggering. From 1990 to 2020, a period of 30 years, there is a 50+% increase of low back pain in not in elderly, but in working age group. I'm sure most of us would agree to that because we ourselves have been going through this issue personally also. But the burden of pain I want to bring to your attention is not just the number in terms of pain, but when your acute or your somatic pain, your nociceptive pain goes unchecked for long, it becomes chronic, and over time, it triggers a cycle that can become neuropathic pain. So, I want you to focus on this statement. Pain is often and most often by most people thought of as a symptom of a disease. Yes, but it might cross that stage, it can become a disease in itself. We'll come to that shortly. And worldwide, even in Western countries, the gap is so much, only less than 10% of the patients receive a multidisciplinary approach to their pain. I want to bring your attention to the definition of pain as given by the International Association for the Study of Pain. They define pain as an unpleasant sensory and emotional experience associated with or resembling that associated with an actual or a potential tissue damage. So, they spent years, invested so much money, put in so much people to bring this definition up. Then they revised this definition. And now they have added a few added points just to ensure that we think about pain rightly. They add saying pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. So now when we think of chronic pain in particular, we should always think of a biopsychosocial model of pain. And it works the other way around. Pain affects all these realms of that person's life. And as a result, the key thing as physicians, compassionate physicians, caring physicians, we need to remember is a person's report of an experience as pain should be respected. I remember during my early training, this idea was naturally put into my heart. When our understanding of physiology and pathology doesn't match to what patient report as pain, we would naturally categorize it as somatopsychological. We make all those terms functional. She's making it up. Her sensitivity is low, as if, we have nothing to do. The reason was we didn't know what to do with that kind of pain. And we always love not to put the blame on us. We as scientific physicians would love to put the blame on the patients. The reason is pain and nociception are not the same. We know the physiology of nociception, some electrical conduction happening, but pain perception is much deeper and broader. And through their life experiences, individuals learn the concept of pain. On the left side of your screen, you have a fairly simple description of the pain pathway. You have the transduction where your tissue injury is translated into an action potential. Then you have transmission, which is where the signals go up. Various first order, second order, third order neurons go to the brain, where you perceive it as pain. That's not always the case. That's often the case with acute pain, but with chronic pain, that's not the case. On the right hand, there is much more happening. And the word perception is replaced by integration and interpretation. You have your ascending pathway, not just going to your S1 and S2 cortex, but it's going all the way to your insula, your anterocingulate cortex, prefrontal cortex, amygdala, periaquedural gay, and all of this cycling back, coming through that green line, forming a very important inhibitory pathway, descending inhibitory pathway. So, I think probably one takeaway today that each of us dealing with patients with pain would be, please take patients' complaint of pain seriously. Believe them. Pain is what the patient feels, not what we feel. Moving on. Now, why do we need a specialty pain clinic? This quote is a partial quote. I have not completed it. About 3 months ago, this patient comes to me, and the first thing the patient says to me is, ഡോക്ടറെ കാണുന്നതിന് മുമ്പ് ഞാൻ തീരുമാനിച്ചതാണ്, ഡോക്ടറാണ് ഈ കാര്യത്തിന് വേണ്ടി ഞാൻ കാണുന്ന അവസാനത്തെ ഡോക്ടർ. ഡോക്ടറിന് ഇത് പരിഹരിക്കാൻ പറ്റിയില്ലെങ്കിൽ ഞാൻ ചങ്ങനാശ്ശേരിയിൽ ട്രെയിനിൻ്റെ മുമ്പിൽ ചാടി മരിക്കും. That's what he said. So I spent some time with that patient. Patient had, it all started just as a frozen shoulder, a very common thing that we all have. But for some reason, it was not managed. It could not be managed. No, all pain cannot be easily managed. It turned out to become a chronic pain and moved into becoming a neuropathic pain, moved into a pectoral girdle CRPS, and our routine analgesics, our routine injections couldn't manage the pain. I want to help us understand this concept with this simple illustration. So there is this battery, this cell, then you have the wire and a bulb. So how does the bulb work? When the connection is intact and the electric signal go from left to right. What if you take away the battery, the cell, but the wire generates electricity? And that is a picture of neuropathic pain. Your nerves are the focus of the disease. So that makes handling pain difficult, and we need an integrated, interdisciplinary approach to handle such pain. Another reason, this is a story of a 35-year-old staff nurse working in a neighboring hospital, a big hospital. She was diagnosed with, again, CRPS, a very bad disease to have. For 2.5 years, she was seen by multiple specialists. She was loaded with analgesics. She was not seen by a pain physician. And after 2.5 years, because her treating physician in that particular doctor moved to another hospital in another city, she was referred to our hospital. And on her first day of visit to our hospital, she was referred to Dr. Vishnu. Vishnu realized that it's not going to be a simple, straightforward pain. He referred to us. I still remember the day she arrived. She couldn't expose her left arm because the mere wind on her arm would, put her into such severe pain, intolerable pain. She had allodynia, hyperalgesia, all of that is needed to categorize her into her disease. Even I'm sure our PMR department, Biju would remember the patient. I had actually sent her to PMR department because I knew we need a teamwork, and we had to work together. I was not planning. Patient was not sent for even physiotherapy that day. Just Biju touching her hand, I think she collapsed in pain, right? Yeah, she even collapsed in pain. And we planned to admit her. The first brachial plex, the therapy was planned as series of dry needling of all the 30 odd muscles of the upper limb and the pector. But unlike regular patients, that it couldn't be done. We need a total brachioplexus block so that needling could be done. Needling along with the sympathetic blocks regularly. The first brachioplexus block, I gave the local anesthesia to the skin. She was unconscious for about 15 minutes. And she was mute for about 6 to 8 hours that day. She couldn't speak because of the sympathetic surge. I was seeing such a thing for the first time. I was early into my pain thing. I was like, no, this is not going to be my area. She's still with us. She somehow believes her condition can be changed, but I'm not giving her much hope. But she has improved much. Mobility has improved. Pain has improved. All my colleagues in the department know she smiles now. But long way to go. This Saturday we are planning a T2, T3 sympathetic block because I feel her sympathetic fibers are bypassing her stellar ganglion because stellar ganglion blocks are not working. Maybe because of the long chronic nature also. This is this is a fully blocked hand. complete high dense brachioplexus block. And after the block, this is how her hand twitches. She's not feeling the pain, but her muscle has got so much intrinsic activity happening in. And this is how it looks like under the ultrasound. All the muscles intrinsically active. The traditional thought process of understanding CRPS cannot explain this. It was always thought of as a sympathetic hyperactivity. But thanks to this senior anesthetist, Dr. Leshmi Was, she is a pioneer in this area. She has treated about 250 CRPS patients to near total cure with stellate ganglion blocks plus dry needle, ultrasound guided dry needlings. I had called at least 5 senior pain physicians in the country. 4 of them said it is useless, no evidence. But because of her published work, I started doing it. I'll come to the results. After this particular lady, we had 3 other ladies with the same diagnosis, but not after 2.5 years. They came to us within 4 hours of diagnosing. The first patient, this is her saying, first time after 4 months, I used my right hand today and I played the piano and sang during our family prayer with my husband. She stays nearby. That was after 4 sittings of ultrasound guided dry needling and 1 stellate ganglion block. The second patient says, first time after 3 months, I could eat with my own hand. After 5 sittings of dry needling with the ganglion block. And in the third patient came to us because seeing the results of the first 2 patients, thanks to our referring primary physicians, our orthopedicians, our hand surgeon, Dr. Thomas, picked up CRPS so early. This patient came to me so early that she was not fearing the disease. So I feared the disease more for her than her. And her response after the recovery was, "Korachokka koranju." And I'll show how much the Korchu Korayal was. On the left side is her hand on the day 1 of the presentation. I want you to focus on her right hand, how much it is flexing. You should also look at the edema of her hand. The color change of the hand is not evidently visible. The moment she walks into the OT, the hand becomes cyanosed. And this is after the Korchu Korayal. So that's part and parcel of our practice. And this is that lady who plays the piano. This is day 1 in severe pain. And this is after about 8 sittings of needling and about 2 or 3 stellate ganglion blocks. So why specialized pain clinic? Because often the conventional care remains fragmented. Repeated analgesics, misdiagnosis, maybe poor follow-up. And more importantly, the complex nature of pain. The interplay between acute nociceptive pain, chronic nociceptive pain, which moves into a neuropathic pain. And now they have a newer category called nociplastic pain, which none of the books explaining that will help us understand. Probably in 5-10 years, we'll understand what it is. That's why they called it plastic. Your understanding can be fluid. To address the biopsychosocial aspect of pain, we need to focus and invest in pain management. Now, why guided interventions? This is not intended to put a blame it's a journey. Medicine is evolving. This is the traditional way we put our needle into the joints, and this has helped multiple patients. But end of the day, your needle is going to touch the cartilage, and multiple studies have proven many times the joint, depending on the skill, the drug might not even go to the joint. But even if it goes, you're going to expose the cartilage And to the exposed cartilage, you're going to put the steroid, and steroid has been proven to be, in the long term with multiple injections, chondrotoxic. But on the right side, you can see the whatever is in the shaded black is the joint space. You can see just above the number 2 an extension of the black space. It's called the suprapatellar recess. So with an ultrasound guidance, you can give your drug into the joint without going into the joint. You target the recess, you don't touch the cartilage. On the left side, you can see drug flowing. That's a needle there. That's a particulate steroid going. The particles are seen. It is going into the recess, not going into the joint. To help us understand that clearly, I have put a Doppler so that the drug going can be seen. I'm pushing the drug intermittently. That's a drug going. Again, drug going. So note that the tissue is not bulging. A 10 ml of drug going, you is not getting a swelling there. Why? Because the drug is freely going into the joint. Again, why guided intervention? This is the neck X-ray, an oblique view of the C-spine. There is a 2E needle, and you can see a black line there. It is the dye spread in the posterior epidural space. This was a patient with radicular pain referred by the neurosurgery department to us. Do you know what the anterior posterior diameter of the posterior cervical epidural space is? Cadaveric studies have shown it to be, even MRI will show the same, 2 to 3 millimeter. So the margin we have to put a needle there is 2 to 3 millimeter. So we need guided techniques for such procedures. And the bevel size of a regular 2E needle is 1.5 millimeters at least. I think I don't have time for all of this. I just wanted to take you quickly through how we handle a case. You know, when a low back ache patient comes, pain physicians think about pain generators. Low back, you have 5 bones, 10 joints, 5 discs, 10 nerves, the cord, multiple ligaments, multiple muscles. Pain can come from any of these, and often more than one of these. So how do we go about it? Often the patient comes with a low back pain radiating to the upper thigh, to the medial thigh. There will be some sort of radiation. With MRI showing some disc, most of us will have some disc bulge. And the tendency is often to call it radicular and attribute it to the disc. We take a meticulous history, we find some of the history points might not be matching. We focus on that. We do some loading tests to find where the pain might be generating. We see if it's actually a radiating pain or if it's a referred pain. Radiating pain is dermatomal, referred pain is not often dermatomal. Then we make a clinical diagnosis. Then we have something important. Under the X-ray guidance, we do an examination to find what is the point of maximum tenderness, to see what level it is, what anatomical structure would be underneath. Then in this case, a facet joint was my primary diagnosis, clinical diagnosis. So we come to facet joint arthropathy cannot be diagnosed with full certainty by any imaging mode. What we do is, facet joints are supplied by 2 thin invisible nerves, but they have a very fixed path, in an anatomical path. So you put your needle tip where the nerve is supposed to be and give 0.5 ml of local anesthetic so that the local doesn't go anywhere. And you find the patient has at least 80%, 90% pain relief. On table, we make the patient do some maneuvers, even take the patient out of the table and walk in the OT. Patient says pain relief. That means your diagnosis is confirmed, and that is called diagnostic block. It's a beautiful technique for interventional pain physicians. And then you go with an intraarticular injection or an RF ablation. Yeah, this is a facet needle tip inside the facet joint, if you can appreciate. I'm moving quickly. The last 5 minutes or 3 minutes, I would like to take you through our journey thus far. You won't believe, 2015, we had one of the pioneers in the country, Dr. Gautam Das, coming here. From what I hear, we had a neurologist who was interested in pain management. I think they coordinated and did some pain camps here. We even had an RF ablator here, but it was not working for the last 10 years. We are trying to get it fixed or get a new one. Then, about 1.5 years to 2 years ago, Dr. Lino started working on pain. Then Lino left us to a different place. He had to go. They moved as a family. And January 2025, I was given the responsibility of looking into this aspect. I was very skeptical, but I had a very encouraging department. Ashu ma'am, Ebi sir, everything was green light. And not to mention the support of our management. GC sir was too supportive, I would say, because his heart was always for patient suffering. But one thing that put so much confidence in me was February 25, my brother could come from CMC Vellore, spent about 3-4 days with me. He's an MSK radiologist. That literally changed my perspective of seeing things. 2025, we got a newer machine for pain, ultrasound. Then Dr. Royce joined us as a clinical pharmacist. So my wish is that he would take up all the pharmacological side, look into drug interactions, to steer the pharmacotherapy on that side. And now the RF ablation machine has been sanctioned. Looking forward to have it and help many patients. A quick look into the stats. The numbers are growing. This is the OPD count. It is a fully and totally referral only OPD because currently I am the only person managing that. So it's going high, but you might ask why there is a dip in September. What happened? We had to travel. So it was a long travel, 15 days we were traveling. And this lady on my left, she has been always by my side. Since Jan, I've asked this question. I'm not sure whether I should pursue this because this is too much. And at this stage of my career, I don't know. Then she would say, if that's what she says. Those who know her would know. So I'm glad she is by my side and my rest of my family too. So I didn't take count of what we were doing. Royce took the count 2 days ago. I realized we had done about 260 interventional pain procedures since Jan. And on the day the patient reported to us, because it was all referral and past conservative management, all patients had very bad pain score. The average pain score was about 9, which is very bad. Grossly interfering with their daily activities, most of the patients. And we called the patient, Royce called the patient over the last 2 weeks. We realized 34% of the patients had no pain, significant pain relief, but 65 patients still have pain. But that's fine, because the average pain score is just 5.4 now. For a pain physician, for chronic pain, you don't have a perfect goal. Current ability to do activities is very much improved. And the duration of pain relief is also good. It is not because the drugs act, steroid act for long, but because you break the pain cycle, you break the chronic pain cycle, you help the patient exercise better physiotherapy. So that's why the whole team is important. And my final slides. So we had quite a few senior people who had put their effort in learning pain in our country, in our state. I had met a few of them 2 weeks ago as I was attending the Southeast Asian conference. It's a sad thing that this specialty has not grown in our state. And the number one reason everyone says is that there is unhealthy competition. There is a fear that my patient, they will take my patient. That is my area of specialty. What are they trying to do in our area of specialty? Fear of losing patient, not trusting others, and also the lack of awareness of what is happening in pain management. But I think we can rewrite the story because our model of care is different. I don't think none of us here uh, uh, fear that I lose my patient, because it's our patient, and our culture is patient centered, people centered. So I hope, and that is probably the only reason why I'm pursuing this specialty and continuing here, because it's not worth pursuing this specialty. It's been proven that it's not worth pursuing this specialty in Kerala, many centers, at least in big hospitals. Looking forward, it's our desire to build a multidisciplinary pain management center to bring out quality. The reason why those 5 senior pain physicians said dry needling is useless is because of the lack of evidence. Yes, because the way we categorize evidence, we don't have meta-analysis, we don't have RCTs, because it's difficult. Given a choice, I would not give dry needling to any of my CRPS patients, because it's one disease where time is important. I cannot put half of my patients as control, not give what I know works. So, but we need to find a solution to bring out research, good quality data. And it's our desire that, and we pray that we would remain patient-centered and people-first. And it's our desire to develop ourselves as an accredited training center, even as we ourselves get trained. Our small team, I'm sure it will grow. Part of the bigger team, the family. Thank you.
Thank you, Dr. Jithin. I know we have a lot of questions from the audience, but I think we're really running short of time because the theatre services are waiting, the surgeons are waiting for us. But I would like, sir, to give us a short message, share something from your heart, sir.
I would have loved to let you all go, but it's such an exciting day for me that I can't but say a few very, very important things, and I hope all of you will listen to me carefully. This particular journey underlines all the beautiful things that can happen within this institution. I want all the seniors, mid-level people, juniors, to think about this even as I spend 5 minutes trying to explain to you. Ashu, when she started, talked about Mass General, how anesthesia started in America. I want believers to be the place where all beautiful things for patients happens. And we are giving you the foundation, we are giving you the space. Please use it to the best of your ability. Don't just be an ordinary Kerala doctor or a nurse or a allied health person. Be somebody very special, bringing happiness into the lives of the people in our state, in our country. Point number 1. Point number 2, Nimmy, thank you for that beautiful presentation. But what struck me was she said 2 beautiful lines: my team, my people. And to Ashu for identifying Jithin, if you go to his home, you will understand why LSQ is such a success. You will see his recording lab, you will see the garden. Oh, that's gone. You will see the fish, you will see the poultry, and you will understand here is a special person who has a lot of other abilities other than just in the area of medicine. Kottayam Medical College, I met Jayakumar sir the other day. I learned that over the years they've tried hard to keep him back, but thank you, Jithin, for choosing to be here with us, and Ashu for identifying him to take up this very difficult area. And as he himself said initially, he was not very sure because that journey so far has been tough, but the journey from now on is going to be much tougher. So I'm grateful to all the consultants, the departments that have already referred patients, and God in His mercy, in His grace, revealed to the team the difference that it has made. And the reason I pushed them so hard was because felt that I'm not a person who tolerates pain, and I had 2 major surgeries, and I didn't feel any pain at all. It's unbelievable. And I kept telling Ashu, I didn't feel the pain. How can we not offer this to the people who are in pain? So that's where we are at the beginning of this journey. But the rest of the journey is going to be tough. We are going to have referrals from all over the country. As Jithin pointed out, at these meetings, he realized that doctors don't want to relieve pain because you lose the patient. Okay? Unfortunately, our patients are not at the heart of our practice in many places in our country. It is a sin. What God has given to us, we have to give it to our people. We have to help our people to be pain-free, to get the very best from what we have learned and what we can give. So, Jithin and Nimmy are batchmates in Kottayam Medical College. What a better way to team up together. But then I know that all your departments, orthopedics, surgery, all these departments have people like this. Can you make teams? Jithin was very sure that he wanted to continue in anesthesia. In any way, Ashu wouldn't have let him go. So they made this beautiful system where he works out of the Department of Anesthesia as a team lead for pain management. All of you can do the same in your departments. So thank you very much, Ashu, AB, Jithin, Nimmy, and the whole team. Thank you to all the others who have referred patients and quietly, quickly. I've been hearing about this with excitement over the last several months. But when you hear it clearly, the first patient Nimmy presented to us, you saw a busy slide, Peter Kumar. I just happened to visit him as part of my chat rounds day before yesterday. He had come from the United States and he had a terrible history of problems, both there and here. Today, he's such a happy man. I would have loved to show him to you because he says, this is fantastic what all of you have done, because he not only had a back problem, he came here on a wheelchair. Today he's walking. He came with a sigmoid colon stricture. Today all that has been treated and he's well. And that is the kind of joy we can give to our patients, and God has gifted us the ability to do it. I hope all of us will join hands together to make the lives of our people really great. Thank you, Ashu, for asking me.
Thank you, sir. So before you leave the stage, we have a small thing to do. We would also like to release our Enhanced Recovery After Surgery booklet. This is a booklet that we've prepared for patients, both in Malayalam and English, particularly for patients undergoing major surgeries.
Can you tell us what ERAS is?
So ERAS stands for Enhanced Recovery After Surgery. That's a perioperative care pathway that we put patients undergoing major surgeries into, so that about 2 to 4 weeks before surgery, they begin to prepare for the surgery, both in terms of their diet, physiotherapy, in terms of the exercises, the respiratory exercises they do. We plan their pain relief, the analgesia, and we lead them. We walk with them before, about 2 weeks before surgery. Our ERAS, we have an ERAS dedicated nurse who keeps talking to them, counseling them, and so they are prepared for the surgery. And so Dr. Neetu Tangam has worked very hard on this booklet, and she's instrumental in bringing out this booklet both in English and in Malayalam. And of course, we have contributions from physiotherapy and Jyoti Krishna, our dietitian. They've all contributed to this booklet, and we hope to give this to patients when they are enrolled in this care pathway. And we'd like sir to release this booklet. So, on the stage, please. I'd invite Dr. AB and Dr. Neetu to please present the booklet to sir.
On behalf of all of you, it's my privilege to release this booklet. I don't like cutting anything, so I like to put it.
sir. Thank you so much. So we'll end the quest session here. Chronic pain OPD, which is going to be functional from next month. It's going to be on the ground floor in just outside the ER OT. So those of you who have 5 more minutes to spare, please join us as we go down and inaugurate the pain OPD, where Dr. Jithin will be sitting 2 to 3 times a week and taking care of your patients. Thank you so much for being with us this morning. God bless you.